we talked about all these different agents that you can use to treat type 2 diabetes, I talked about them in the order that you might encounter them if we think about the normal pathway that glucose is absorbed into the body and then stimulates insulin release and then insulin downstream effects. Over here, you can see I have listed these agents in a slightly different order, and I listed these agents in this order to better help you understand what some of the first line and then maybe second line or less commonly used agents will be that you'll encounter on step 1. So first, we talked about your bicarbonate, such as metformin. Remember, by increasing insulin sensitivity and inhibiting MGDP, this is going to lead to decreased gluconeogenesis, right as we saw over here. Decreased gluconeogenesis is one of the normal effects of insulin, so this, of course, is going to be helpful when treating insulin insensitivity. Additionally, by inhibiting glucagon, metformin is also going to lead to increased glycolysis, increased peripheral glucose uptake, all of these things that insulin should normally be doing, but is not potentiating these effects as well as it could be because in the setting of type 2 diabetes, you have some resistance. Now, for all these agents that we talk about, of course, there are side effects. And a very important side effect for you to be aware of in regards to metformin is B12 deficiency. B12 deficiency can result after prolonged use of metformin and is a frequently tested complication. So if a patient on metformin starts developing peripheral neuropathy and that stock and glove distribution, or they have a megaloblastic anemia, definitely think about B12 deficiency. Additionally, weight loss, GI upset, and lactic acidosis can result from metformin. Now, metformin is probably the most commonly used first-line agent for the treatment of type 2 diabetes. The next 3 agents we talk about, there's some controversy about which one you'll use, and it's a little bit patient-specific. It's also a little bit cost-specific as well. But these next 3 are also big players that you should be aware of in the treatment of type 2 diabetes. Starting out with your SGLT2 inhibitors, these are all the things that work at the level of the kidney and help you pee out extra glucose, canagliflozin, dapagliflozin, and pagliflozin, decreasing resorption of glucose at the proximal convoluted tubule. It is important to know that this occurs at the proximal convoluted tubule that is sometimes tested. And side effects here can include weight loss, which a lot of patients are very happy about. Glucosuria, that is what can cause UTI in some of these patients. So because there's so much sugar in your urine, it becomes very attractive for bacteria to colonize that urine. And that can result in UTI as well as vaginal candidiasis through a similar mechanism. And then orthostatic hypotension or dehydration. Because there's more sugar in that urine, it also osmotically can pull in more fluid. And that can lead to dehydration in this population, which of course can contribute to HHS as well. Additionally, decreased function with decreased GFR. If your kidneys ain't working and you're not making enough urine, then pulling more glucose into that urine is not really that helpful. Now, if you talk to a lot of endocrinologists today, they are very, very excited about a newer class of drugs, these GLP-1 agonists. Some endocrinologists will say, GLP-1 agonists are kicking SGL2 and sulfonylureas out of the water. They are the best drugs aside from metformin to treat type 2 diabetes. They're super expensive and a lot of insurance agencies will not cover them initially. So that is part of the reason that you may still see SGLT2 inhibitors or sulfonylureas used as second-line agents preferentially instead of GLP-1 agonists as a cost issue, which of course is unfortunate. But examples of GLP-1 agonists are exenatide, liraglutide. They decrease glucagon release. They also decrease gastric emptying and increase insulin release. As we talked about down here, remember these GLP-1 agonists closing our potassium channels. As they close the potassium channel, leading to downstream release of insulin within pancreatic beta cells. Additionally, having the delay of gastric and decreased glucagon release helps potentiate the effects of insulin. These drugs are also associated with weight loss and a little bit more dramatically so than your SGLT2 inhibitors, which is another reason that so many endocrinologists are excited about these agents. They increase satiety. They may be associated with nausea or vomiting. And then a very important complication for you to be aware of here is pancreatitis. This is commonly tested, even though it's not commonly seen as a complication of GLP-1 agonists, but you should be aware of it for step 1. In addition to our GLP-1 agonists, sulfonylureas are also common second-line agents for the treatment of type 2 diabetes. The first generation sulfonylureas are chloropropamide as well as tolbutamide. These are not used as commonly as our second generation agents, which I think are more high yield for you to remember. Glimepiride, glipizide, gliburide, this ending of ride very much associated with your sulfonylureas. These function, as we talked about down here, the pancreatic beta cell closing potassium channels in the pancreatic beta cell, leading to increased potassium within that cell, opening those calcium channels and then leading to insulin release from the beta cell. Association with these are hypoglycemia. So hypoglycemic events are very dangerous in the setting of type 2 diabetes, and sulfonylureas can contribute to them. Additionally, weight gain. So not as nice as our GLP-1 agonists and SGLT2 inhibitors, which can cause weight loss. Sulfonylureas can actually cause weight gain, which can be very frustrating for patients with type 2 diabetes. Next, we have drugs that are a little bit less commonly used, but still certainly seen in practice, are DPP-4 inhibitors. All of these, remember, they have the gliptin suffix. GLP stays in here because down here are DPP-4, since it is less activated, will not be breaking down GLP-1 as much. This leads to more GLP-1 in circulation, more GLP-1 activity, the benefits of which are delayed gastric emptying, as well as increased insulin release. DPP-4 inhibitors are weight neutral, so you're not going to see as much weight gain here, but you might see increased urinary infections again. Also in this less commonly used but still seen group are your glitazones. These are things like pioglitazone, rosiglitazone, and these activate PPAR gamma. Remember PPAR gamma up here? The only thing I want you to remember about it is that it is going to increase lipid synthesis. Increased adiponectin is the mechanism by which we get increased insulin sensitivity, as well as change in regulation of fatty acid storage. But we are increasing lipid synthesis with our thiazolidinediones, which activate our PPAR gamma nuclear receptor. Because they are increasing lipid synthesis, it should make sense to you that weight gain can be associated with the use of these drugs, as well as edema, heart failure, and increased risk of fracture. These drugs are not recommended for a patient who already has heart failure or who has really bad osteoporosis. The next group of drugs is our alpha glucosidase inhibitors. Remember, these are going to be drugs that are working at the intestinal brush border to inhibit the enzyme alpha glucosidase. Alpha glucosidase, once inhibited, is going to delay glucose absorption, which leads to less postprandial hypoglycemia. So you're not getting that flood of glucose all at the same time. Examples of these are Cabros or Miglitol. They can be associated with GI upset. They're not really recommended if the GFR is low because these drugs are renally excreted. And then lastly, and in this case, definitely leastly, is insulin. So we do not want to put patients with type 2 diabetes on insulin. If we have put them on insulin, it means that they have failed otherwise medical management, including whichever combination of these drugs that we use to attempt to control their A1C. Insulin is a last resort drug for patients with type 2 diabetes. We want to keep them off of it as long as possible. However, if the choice is rampantly uncontrolled hyperglycemia and diabetic complications or insulin management, we will use insulin to manage type 2 diabetes. We've already discussed all the different types of insulin. I've also included them here for your reference, but refer back to the type 1 diabetes medical management for a more in-depth discussion of the different types of insulin. So I know that was a lot to remember. This is a very dense, complex video, but to quickly recap, think about this mnemonic whenever you think about management for type 2 diabetes, the STAD mellitus with DAGs, to help you remember all of the different drugs that can treat type 2 diabetes. And then if there's only a few drugs that you're going to remember, only a few things you're going to take away from this video, I would really want you to focus on this top section included on the left up here. Metformin, which is working to decrease gluconeogenesis as well as increase the effects of insulin glycolysis and peripheral glucose uptake. Your SGLT2 inhibitors, which all end with your lovely suffix of flosin, which are helping you pee out extra glucose. Your GLP-1 agonists, which are exciting new drugs that can also cause weight loss and work by increasing GLP-1's ability to increase the pancreatic beta cells releasing insulin, as well as delayed gastric emptying. And then your sulfonylureas, which are working by closing those potassium channels, then leading to the downstream closure of those calcium channels and the release of insulin within the cell. If you only remember 4 drugs, remember these 4 drugs, and that should help you get some points on step 1. Now, how they ask you about this in a board style question? Well, something they might ask you is a 67-year-old man with type 2 diabetes, hyperlipidemia, and hypertension presents to his PCP for a 3-month follow-up. His current medications include metformin, lisinopril, and rosuvastatin. His last A1C was 7.3. He has a history of chronic pancreatitis and is currently working hard on an exercise program to lose weight. He does not want to start a medication that might interfere with his weight loss. What medication would you recommend? Well, right off the bat, we know that an A1C of 7.3 is high. Our goal is below 7. So his diabetes is not perfectly managed here. He's already on metformin, so we need to choose an additional agent to help control his diabetes. Going down our list on the side here, we could choose an SGLT2 inhibitor, we could choose a GLP-1 agonist or a sulfonylurea, but he has a history of pancreatitis. So we know that maybe a GLP-1 agonist is not the best choice for him, considering that a rare but potential side effect is pancreatitis. Additionally, we know that he is worried about weight gain and he's working really hard to lose weight. So we probably don't want to give him a drug that has a side effect of weight gain, like a sulfonylurea. For those reasons, I would most likely choose a SGLT2 inhibitor for this patient. It's high up in our list of secondary agents to treat type 2 diabetes. It can cause weight loss, so may actually help him with that respect, and it has no side effects related to the pancreas that we know of. Now, that's all I have for you on management of type 2 diabetes. I hope this video was helpful, and I'll see you next time.